Okay. So we went on to look at the movement of solids or fluid, which we said requires two things. That is between two compartments. Okay. It requires a force and a channel. Both have to be available for movement to occur. When one is not there and the other is there, no movement will occur between two compartments. Okay. Let me give examples of the different forces that can occur. Okay. So constant gradient give you diffusion or osmosis. Aerostatic pressure, and the electrical forces. Okay. So you have to have a semi-permeable membrane for movement to occur. So the semi-permeability is depending on the presence of the force and the channel being there. So the body has got different channels at different parts of the body, which allows for these movements to occur. Okay. Now, when we go back to the sodium and how it affects movement of water, okay, we said sodium will determine, the concentration of sodium determines the intracellular volume. Okay. So the more sodium you have outside, the smaller the cellular volume will be. The greater the sodium, okay, the smaller the cellular volume. The lower the sodium concentration, the greater the cellular volume. And this is what causes the symptoms that you see in a patient with hyponatraemia. Okay. They occur because of the volume changes caused by the sodium. So why does that happen? Is because plasma osmolarity is mostly dependent on the sodium concentration. Okay. So the greater value of the plasma osmolarity is due to sodium. What's the formula for plasma osmolarity? So plasma osmolarity is equal to, so trying to get the sum of all the osmos in blood, both negative charges and positive charges, plus non-charged particles. Okay. So what's that sum? Okay. Okay. So I said all the charged particles, positive and negatives, plus the non-charged particles. Which are the non-charged particles that are prominent in blood?
Non-charged particles. Proteins.
So glucose.
Oh, glucose is glucose actually.
Okay, glucose and urea. Okay. For the charged particles, what you do is you do 2 times sodium. Okay. So I'm multiplying the sodium by 2 because the negative charges are equal to all the positive charges in the blood. So because you can't measure each negative charge individually, you may measure your chloride, you may measure your bicarb, okay? But you cannot measure other negative charged particles like the proteins that you mentioned. Okay. So what you do is you just multiply the charge of the sum of all the positives by 2. For electrical, since there is electron polarity at all times. So that's why you multiply this by 2. If you want, you can put your potassium, or you cannot put it. So negligible. Most times it's never put there. Plus urea, plus glucose. You see? Now these would be maybe 5 urea, glucose 5, 10. But predominantly, if this is 140 for instance, 140 times 2 plus 10. So this will give you 290. Okay, that will be the osmolarity. So what we are saying here is predominantly it's a sodium concentration which will affect the osmolarity. If sodium goes down, instead of 140, it comes down to 110. So that will be like that plus 10. Everything else will remaining the same. This will be 230 will be osmolarity. You've seen it. So that's a very drastic reduction in osmolarity from what is normal. And what we said is movement of fluids, water particularly, between compartments. Now we go back to this. Okay? So movement of water is dependent on the plasma osmolarity being equal to the brain cell osmolarity, or any other cell for that matter. Okay? So if your osmolarity has now become 230, and here it has remained at 290, because what you've lost, what has changed is osmolarity in the plasma. In the cells, the change doesn't occur very quickly. It takes time for it to go down. Okay? So where do you think the water will go?
The cells.
Okay? So water will move in this direction. Okay? From the plasma into the brain cells until you get these pressures to becoming equal. So as water is moving there, the osmolarity there will start dropping. Okay? Because the volume of water will be higher in the cell now without changing the osmos that are there. So osmolarity in the cell will fall until it's equal to osmolarity in the plasma. So as water is moving into the cell, obviously the osmolarity will be getting higher because you're losing water. Okay? And the osmolarity there will be getting lower until it's equilibrium. And water movement will stop. But what would have happened is that the intercellular volume would have gone up when there is a reduction in concentration of sodium. Okay? So why you start seeing those symptoms that you mentioned, symptomatic hyponatraemia, which tells you that this is an acute process, is because the cell volume is expanding, the brain is encased in a rigid skull. Okay? So the intracranial pressure is actually going up. And as it goes up, you start with those minor symptoms, headache, lethargy, nausea, okay? Then you see your patient having seizures and going into a coma. Okay? So if you find hyponatremia in that setting, you know this is acute. Okay? And the only way to rectify those problems is by increasing the plasma sodium concentration rapidly. So you have to give something which can quickly raise the concentration of plasma sodium. You understand? Now, in chronic hyponatremia, what happens is different. So, because the sodium concentration is dropping at a slow rate, the body has a chance to export osmos from the cells. Okay? So these osmos are referred to as idiogenic. So that's a term which you need to know and which has to become part of your vocabulary. Idiogenic osmos. Okay? So the idiogenic osmos include things like potassium, which is highly concentrated in the cell. Okay? And amino acids such as taurine. So you follow. So potassium, taurine, the body will start exporting these out. So as these are being exported, the cellular osmolarity is also dropping at the same rate as the plasma osmolarity. So there's no change in terms of water movement. Water will not shift in chronic hyponatremia. because the body is able to export these hormones. You follow? So these patients will not become symptomatic. There will be no seizure, headache, all the things that go with chronic hyponatremia. So that's basically the difference between acute and chronic hyponatremia. So in acute, the drop in sodium is sudden, whereas in chronic, osmosis are the difference between acute and chronic hyponatremia. And these come into play when the loss of sodium or the concentration of sodium decline is gradual. Okay? So if it's acute, you get acute hyponatremia with shifts of water from the plasma into the brain cells, which makes the brain cells to become larger, and hence the symptoms that you see. If it's a gradual drop, there is compensation by exporting of potassium and chlorine from the cell with no change in brain osmolarity, hence no fluid movements. That makes it chronic hyponatremia. And that's why those two conditions need to be distinguished. So the idea for chronic hyponatremia is for you to know what's causing the chronic hyponatremia. Okay? So we can talk about, so acute hyponatremia is just where you add water to the patient, okay, who is not able to refuse the water that you're giving. Our patients in ICU, 5% dextrose for one reason or the other. Post-operative patients, okay, where they use, especially these procedures which require cauterization. So when you're using cauterization and they're doing a procedure and you have to irrigate the patient, okay, they don't use saline. For saline is a charged, salt is charged. Okay. If you use electricity with a charged particle, you're actually going to shock the patient and yourself, most likely. Okay. So you find that they will use saline to irrigate. Okay. When they're doing prostatectomy, they will use glucose. Okay. They won't use saline. Okay. And that glucose which they use results in a lot of it being absorbed into the system. And that's what causes the sodium osmolarity to drop.
So it causes dilution of hyponatremia.
And it can
So most of the times it's iatrogenic. It's us who
It's
causes
us who causes it. Most of the acute.
Then again we have to correct it.
Yes. So you have to be aware that you've caused it and what you need to do. There are of course those patients who come with acute hyponatremia from outside the hospital. Those are special cases. Marathon runners. Okay. How many of you do any running of any kind? Marathons? Nothing. So marathon is 42.2 kilometers of running. So most of those patients usually you find they'll put water at different spots. As they're running, they'll find water to drink and they continue running. Those patients, particularly those who are inexperienced, amateurs like myself, if I did at the marathon, I may end up with a seizure at the finishing line, if at all I manage to finish the race. Okay? I'll end up with hyponatremia. The experienced runners don't get hyponatremia. Okay? A female is more likely to get hyponatremia when they are doing marathon as compared to a male. There are reasons why all those things happen. So most of the slow runners tend to take longer on the circuit. The rest will start when it's dark. Okay? But the longer you take, the daylight will find you on the road still running. You will sweat and all those things. Okay? If you are fast, daylight, you will be exposed to a shorter period of daylight. That's one. Two, you drink less water. The slow ones will stop. When you see Coke on the station, you may even take two and drink. You understand? The first ones have no time for that. They'll just take maybe one, quench their thirst and run. The slow ones will drink a lot. Okay? So all those tend to become hyponatremic because of they have taken in too much water. The salt has not changed. You understand this? So they become hyponatremic and they can have an acute seizure. People who take drugs like ecstasy, Okay? Ecstasy will make you drink water without realizing that you've drank too much. Okay? You find people going to bars to drink beer, they'll take some ecstasy just so that they can drink more beer. Okay? It blunts your thirst effect. So you'll just be drinking without being aware that you've drank too much. Okay, that's ecstasy. That's why you find in some nightclubs, people, the owners of the bar, they want to make sales. So they also sell some illicit drugs in there. Okay. Then other people are prone to hyponatremia, apart from the ecstasy. People with schizophrenia, the crazy, okay? Like where you just like today I'm just going to drink 10 liters of water. You who is not schizophrenic, obviously you wouldn't think you can drink 10 liters of water. And the guy will just be there and the water is there, just drinking, and he'll drink until he starts having a seizure. Okay? And then those people have been advised wrongly, water therapy. Dr. Ushanga, patient comes, no BP, just drink lots of water. How much? Just drink, there's no harm in water. Water is the best drink. And the patient will follow your instructions. 5 liters of water in 24 hours. Okay? Gulp, gulp, gulp. They'll come with a seizure, and then you'll be wondering, is it malaria or whatever? Cause of seizures? Dr. Ushanga. Okay? So, those are the conditions from outside the hospital, where one can come with acute hyponatremia with seizures. Okay?
The syndrome of inappropriate ADH secretion.
Yes.
Most of it, is it acute or chronic?
It's a chronic.
Chronic most of it.
Yes. So it's one which under chronic, I want now to tell and how you approach the. Okay. So when you see a patient with chronic hyponatremia, okay. So they have their own emergency, which you have to be aware of, and we'll discuss it as we go on. So under chronic hyponatremia, so it's the same thing. The sodium concentration would be low, so less than 130 millimoles. We know normal sodium is 135 and above, but we start getting worried when it goes below 130. Okay. So this has been an arbitrary cut-off point, 130 millimoles per liter. You have to be concerned. Okay. So in chronic hyponatremia, when you see a patient with chronic hyponatremia, what you start thinking, what should go through your mind? You've excluded acute, which is symptomatic, and which is an emergency by itself. Now you're saying this is chronic. Okay? When you see this one, the number one question to ask yourself is ADH working? Okay? Is ADH present? You want to answer that question. Each time you see chronic hyponatremia, your mind should quickly switch, your thoughts should quickly switch. So we said first you see hyponatremia, you ask yourself acute or chronic. Acute, you deal with it immediately. Chronic, other questions come into play. Okay? Is ADH working or present? That's question number one. Okay? Then question number two will depend on how you answer question number one. Okay? So, is ADH secretion appropriate? That's a question, second. Give you some chance to recover. So, how do you answer the first question? Is ADH working? Maybe I'll try to answer it right here. Or the better way to answer it is by diagrammatic depiction. So we know that ADH works at the level in the kidney, okay? The cortical collecting duct. That's a point where you get your ADH having its effect, okay? So what it does, if it's there, it will attach to its receptor, okay? The ADH receptor, and then cause the insertion of aquaporins. This is the urine side. This is the blood side of the cell. Cortical collecting duct, okay, cell. So aquaporins, when they are there, okay, remember we talked of the channel and the force. So there will be osmotic difference between the blood and the urine. Osmolality there is higher than osmolality in the urine at this part of the CCD. Okay. So what tends to happen is if aquaporins are present, water will then move down its concentration. It will move from where there is more water to where there is less water. You understand? So when you see this happening, so water will come this side. Okay? And what will happen here is that the osmolarity in the urine, when water moves out, what will happen to the osmolarity? Will it go down or go up? Okay. So urine osmolarity will be high. When you find high urine osmolarity, it's telling you that ADH is present. Okay. So to answer the first part of the question, which is ADH working, you look at urine osmolarity. Okay. So high urine osmolarity equals ADH present. So urine osmolarity will be higher than plasma osmolarity. That's what defines high urine osmolarity. It's just you compare how is the plasma, how is the urine. Okay. So it tells you that ADH is present when urine osmolarity is high. So if you find that ADH is present, the next thing you ask yourself is the ADH secretion appropriate? Okay. How do you answer whether this ADH secretion is appropriate? Okay. Now I'm trying to answer the second part. The first part we've answered, ADH is present. Is it appropriate? What you look at is, number one, what is the BP for the patient? Okay. So if the patient is hypotensive, ADH is present and patient has hyponatraemia. Okay. Then this is appropriate ADH secretion. You follow? So, for as long as there's hypotension, ADH will be present. Okay? Because if you remember, the names of ADH: vasopressin and the antidiuretic hormone. Okay? Now, this name vasopressin, that's why it has got two names. Other things just have one name. This one, two names. Okay? Why? Vasopressin is the most important function of ADH. Okay? So its first job is to rectify the BP. They don't care what the sodium is. Whether sodium is 10, if the BP is low, vasopressin will be secreted. Okay? So that secretion is appropriate ADH secretion because there is hypotension. You understand? So when you secrete the ADH, aquaporins will be inserted there and water will keep being taken in. When water comes in, okay, this water which is coming in, let me put it here, over sodium. So you're getting the water is going up, okay? The sodium has remained the same. So you actually be worsening the hyponatremia for as long as your BP is low. Okay? So the only way to switch off the presence of ADH is to rectify the BP. Okay. If you get the BP up, whichever way you do it, the ADH will switch off. Okay. And when ADH switches off, this water, which is being filtered here at the glomerulus, okay, will be lost in the urine now. And the plasma sodium concentration will start going up. You understand me? So now, second scenario would be normal BP. So if you find there is normal BP, there is hyponatremia, and you find ADH is present. Okay? Are we following? You still ask yourself. So there is normal BP, hyponatremia, ADH is present. You ask yourself the next question: is this appropriate? What's your answer? Mm-hmm. Normal BP, hyponatremia, and ADH is present because the urine osmolality is high. Okay. Yeah. So is that appropriate ADH secretion? Of course.
In relationship to the blood pressure.
So at that particular point, you're going to say this is syndrome of inappropriate ADH secretion. You understand that? So it's part of the chronic hyponatremia. ADH is present, and its presence is inappropriate. So not all hyponatremia with ADH present is inappropriate. I think that's a key message. It's inappropriate when there is a
When the BP is
normal BP. Okay.
So could it, it's not possible that the ADH being secreted there and the water being retained has helped to normalize the BP?
No. In that particular situation?
No, I'm saying the essence of the vasopressin, is it not in an attempt to normalize the BP?
Yes, that's the
So there
essence.
is no point at which it actually manages to normalize it.
It may normalize eventually, but your issue is what you found at that particular point. Okay.
All right.
Is it appropriate or inappropriate?
Oh.
Okay. And then you will see the danger that comes with this chronic hyponatremia when, even just by looking at this picture, and what happens when ADH disappears, which is the danger of chronic hyponatremia, the disappearance of ADH. Okay. So when you find this situation, okay, you decide that this is inappropriate, syndrome of inappropriate ADH secretion, okay, of which you know if there is hyponatremia, okay. So hyponatremia, when it's there, should switch off ADH secretion, okay. That's a normal scenario. When you've got your sodium is becoming, concentration is dropping, the body switches off ADH secretion. When you get below 135, okay, millimoles of sodium, ADH secretion stops. When you get above 145 millimoles of sodium, ADH secretion starts. That's how the osmostat works. Okay? Low sodium, no ADH. High sodium, ADH. And that balances out the hyponatremia. But when you get to less than 135, and you still have ADH being produced, okay, that is syndrome of appropriate ADH secretion if the BP is normal. Then the question is, why are you having this inappropriate ADH secretion? Okay, that's the question you should always ask yourself. When you've arrived at the definition that this is inappropriate, you ask yourself why. Okay, so the why that you have, any examples, any reasons why to continue being there?
Infections.
So infections, okay. So you can have infections in different parts. CNS infections, pneumonia, okay. All these things can cause ADH secretion to continue, okay. Number 2,
neoplasms,
sorry, cancers, okay. So these cancers can by themselves secrete ADH, okay. Just the cancer and ADH is one of the things which they make, and that will not be subject to control by sodium concentration because they are autonomous. They'll just continue producing. Okay. Pain. So somebody can just be in pain because they're in pain, will produce ADH. And for as long as the ADH is there, because the pain is there, they'll continue retaining water, which will worsen the hyponatremia. You follow? So your job is to find what is causing. Okay, there are certain drugs which can also cause continuous ADH secretion. Okay. So look at the drugs that the patient is on and check them out to see does this drug induce ADH secretion. Okay. So the treatment point would be for chronic hyponatremia would be to remove what is causing ADH secretion to be there. Okay, for syndrome of inappropriate ADH secretion, if it means treating the infection, treat it. If it means removing the malignancy, remove the pain. If it means treating the pain, stop the pain. If the drugs that the patient is taking that you need to withdraw those drugs. Okay? So, what will happen is when you sorted out whatever the cause of ADH secretion, okay, once you've dealt with it, so ADH secretion stops, okay, meaning this aquaporin will not be there anymore, meaning water will not be taken up, meaning the urine osmolality will drop, okay, because the water now which is coming from here is being lost, so the water volume will decline. The sodium concentration will start to normalize. You understand? So by treating the underlying cause of the ADH secretion, you actually rectify the hyponatremia, and the patient will become normal, but may end up becoming hyponatremic. Okay? And that's the danger of treating chronic hyponatremia. So the danger in chronic hyponatremia is that your patient can become hyponatremic too quickly.